Hello, everybody. I am Dr. Ranjana Advani from Stanford University in California, and I will be presenting new updates in the management of lymphomas from a patient's perspective. These are my disclosures. So let's start out with the basics as to what is lymphoma. Lymphoma is a family of blood cancers derived from mature lymphocytes, which can be B cells or NK cells. Lymphocytes normally fight viruses, bacteria, fungi, and foreign organisms, and lymphocytes travel in the lymphatic system, and they can grow in nodal or extranodal locations when they become a lymphoma. So how common is lymphoma? So you can see that in males, it's about 5% of cancers, and in female, about 4%. And the number of deaths also is about 3 to 4%. So it's not as common as lung cancer, prostate, or colon cancer. Nonetheless, it has its own complexities. So there are about 80,000 new cases a year and 20,000 deaths a year. And at a time, because treatments are fairly successful, more than 500,000 people are living with lymphoma. And Hodgkin's and non-Hodgkin's lymphoma affects both genders, all ages, and all races. So this is the age distribution. So if you can see in non-Hodgkin's lymphoma, it tends to be a disease of people over 60. Whereas if you see in Hodgkin's lymphoma, there are two peaks. One is when people are in their 20s to 30s, and then the second one in the 70s, but it's not as common as non-Hodgkin's lymphoma. And what causes lymphoma? One really doesn't know. So of course, we see it more with increasing age. Then there are abnormalities of the immune system, which could be inherited or related to other conditions such as treatment, which causes immunosuppression, HIV infection. Some viruses can lead to lymphoma, exposure to certain chemicals, and some bacteria. And of course, we don't know the role of genetics, environment, diet, or lifestyle. It's plausible, but we have nothing to say that altering this will prevent a lymphoma. So there are more than 80 different types of lymphoma, and the commonest ones have been circled in blue. And you can see that amongst the aggressive lymphoma, diffuse large B-cell lymphoma is 30%, whereas follicular, which is more indolent, is about 25%. And then you have the other rare lymphomas, which are anywhere from 5 to 7, 10%. So the goal of treatment depends completely on the disease we're dealing with. So for diffuse large cell lymphoma and Hodgkin's disease, the goal is cure. Whereas in follicular lymphoma, which tends to behave more like a chronic disease, the goal is symptom management. And T-cell lymphoma, mantle cell lymphoma, they're very aggressive, but the goal is to obtain remission and have prolonged disease control, because by and large, they are not really curable. So it was simple in the days of chemotherapy, because that's all we had. And chemotherapy targeted the DNA or some of the other pathways, the topoisomerase enzymes or the microtubules. And we used rational combinations using non-cross-resistant chemotherapy agents to try to outsmart the cancer cell by killing the cell and the way it multiplies and divides. It's become a lot more complicated because now we know so much more about the biological heterogeneity in a lymphoma. There are aberrant signaling targets, there are mutations, there are immunological targets. So now we have like a plethora of targeted therapies, all with novel mechanism of actions. And I'm going to try to walk you through some of this new data. So if you just look at immunotherapy of lymphoma in 2021, we can either target the tumor or we can target the host. And what I have highlighted are the agents I'm going to cover. So when you target the tumor, you can do it with something called CAR T cells, with antibody drug conjugates or bispecific antibodies. And for targeting the host, how do you remove the checkpoints on the immune system so that the immune system can attack the cancer cell within the person's body? So in large cell lymphoma, when patients relapse after receiving therapy, the standard of care is you give more chemotherapy and take patients to transplant. So then they relapse after transplant, and then their outcomes are really very poor. And you can see that the overall response rate in patients who fail a transplant is only about 26% and really low complete remission rate. And that's across all subgroups. And you can see that if the patients, only about 20% or so survive at 5 years, and most of the patients die within the first 2 years once they relapse. So that is certainly an area where a lot more improvement is required. So chimeric antigen receptor called CART, modified T cells called CAR T, They are genetically engineered T cells, which are altered to express this artificial receptor called CAR. And you can see this is a normal T cell, and this is where this unique receptor has been expressed. And the benefits for this is that it can target the tumor very easily. It allows the T cell to kill the tumor. And while it has complicated manufacturing techniques, it can localize pretty well to the tumor. Now, we have 3 different agents approved in the United States and 2 in Europe. And one is called Axicell, one is called Tisacell, and one is called Lysocell. And I think you have to just think of these as largely similar rather than different, though there are nuances, and what one can get versus not get depends on the center where these are being given and how much expertise there are. But if you look at the efficacy across the board in patients with very relapsed or refractory disease who've had 3 prior lines of therapy, you can see that the overall response rate is anywhere from 50 to 80%. And there are different ways of measuring response. So I would say that the complete remission rate is also 40 to 50%, which are very similar. And the duration of response for these drugs seems to be at least a year. And the overall survival for this agent Axicell was approved first, so we have longer follow-up. It looks like for the patients who go into remission, they're surviving for at least 2 years. And for the others, the follow-up is shorter, so it's at least a year to 2 years. And this is far better than what I showed you, where only 20% survive 2 years and 80% of the patients die in less than 6 months. So because it is so effective, there are trials going on to see, can we move it a little bit more to the frontline setting? Like, why do we have to wait till somebody relapses? So there is a trial which is ongoing, and some preliminary results were presented. So what this trial shows is they took patients with very high-risk lymphoma, which had certain molecular definitions called a double hit or a high score, and they got standard therapy. And they got it for 2 cycles. And then they did a PET scan. And if the PET scan after 2 cycles does not show an adequate response, instead of continuing with the same therapy, which is not working, they switched and they gave the patients the CAR T cell. And the primary efficacy was to look at the complete remission rate. And you can see with this strategy, 27 patients met that criteria and was switched early in the game to this CAR T. And you can see the overall response is 85% with about a 74% complete remission rate. Now, of course, we need a much longer follow-up, but at least at a follow-up of about 10 months or so, the median duration of response or progression-free survival, overall survival has not reached, suggesting that patients are doing quite well. The other question is, we know that patients who relapse, the standard of care is to take them to autologous transplant. Well, if CAR T is so effective in patients who have failed a transplant, what if we do it earlier in the game in patients who have relapsed? So there are 3 trials which are looking at this question at first relapse in large cell lymphoma. So patients are then randomized to get standard of care chemotherapy, which is giving them salvage followed by a transplant, versus doing CAR T therapy. So you can see that there are 3 trials, and of course there are nuances of exactly what kind of patients went into it. But at the broadest level, there have been 2 press releases. We haven't seen the data both in June, one from Bristol Myers Squibb with the Lysocell, which shows that in the Transform trial, the CART arm is looking better than the transplant arm. And similarly, Gilead announced in later June this year that the event-free survival was 60% better compared to chemotherapy plus transplant. So again, we have to stay tuned to what the details of these results are, but this could have the potential of changing practices and how we treat our patients. CAR T is also approved, the agent Axicell, for relapsed mantle cell lymphoma in patients who have failed the BTK inhibitors, or in follicular lymphoma who failed at least 3 prior lines of therapy, again, with amazingly high response rates of 80 to 90% and very high complete remission rates as well. So antibody drug conjugates are a different class of drugs where you have an antibody to which a potent cytotoxic drug is conjugated. And it allows the drug to get very focusedly delivered to the tumor because it's preferentially delivered. So you can get the increased drug at the target And you also reduce normal tissue drug exposure, so you improve the therapeutic window. And in large cell lymphoma, there is a drug called loncastuximab, which was approved earlier this year in April for patients with large cell lymphoma after 3 prior lines of therapy. So lonca binds what we call CD19, which is seen on all B-cell lymphomas and aggressive lymphomas, and it's conjugated to a PBD dimer, which is a cytotoxic agent. So this enters the cell, and there it sort of gets broken up, and then this PBD dimer, which is the potent cytotoxic agent, gets into where it needs to do its business and blocks the cell division, and then the cancer cell dies. So this has been looked at in something called the LOTUS trial, and you can see that about 48% of the patients responded. And in patients who achieved a complete remission, the median duration of response has not been reached. And for patients who had a partial remission, it's about 14 months. And you can see that the overall survival is about 10 months. So again, it's something which is active in patients who are heavily pretreated and don't have other choices. And of course, now it's being looked at in combination with other drugs in the frontline setting, as well as in the relapse setting, combining it with other chemotherapy agents. Now, bispecific antibodies combine the 2 antibodies so that they can simultaneously bind to different antigens. So one binds to a B cell, one binds to a T cell. And so you basically have the T cell come closer to the B cell where the lymphoma is and allows it to kill the lymphoma cell. So we have 4 emerging bispecific antibodies which are undergoing clinical trials. And if we look at the results of these 4 trials across the board, again, these are in patients. I'm just showing you this data in aggressive lymphoma. They're very active agents with, you can see an overall response rate in very heavily pretreated patients of about 50 to 60%. And unlike the CAR T where I showed you the data, these are much less toxic. So CAR T therapies have a lot of cytokine release syndrome and neurological toxicity, which makes those therapies difficult to give in the community. And you can only give it in major academic centers, which have the infrastructure, the expertise, and ICUs to support that kind of therapy. These agents can actually be given quite easily in a regular infusion center. So we have to stay tuned to where this is going. One abstract, which I thought was very interesting using these agents, was in elderly patients with first-line large cell lymphoma. So patients over 75 are not able to tolerate regular chemotherapy if they're unfit or have cardiac issues or diabetes or other things. And in those patients, we tend to use homeopathic chemotherapy or reduce the doses, and then the outcomes are not that great. So one of the bispecific antibodies, mosunetuzumab, has been tested in that setting. And you can see that the overall response rate, now this is no chemotherapy, this is just this bispecific antibody. The overall response rate is 65% with a complete remission rate of 45%. And you can see that these are patients in green who are still on treatment. That means it's working. And the early clinical data suggests that it's quite efficacious and manageable with acceptable profile. So again, we have to stay tuned for how this does in the longer term. Moving on to the last part of my talk on Hodgkin's lymphoma, where the checkpoint inhibitors have played a major role. So again, as in non-Hodgkin's lymphoma, for patients with Hodgkin's lymphoma, if you relapse, the treatment is giving chemotherapy and taking patients to transplant. And with that, you can expect to cure about half the patients. And the one single determinant of how to, the patients who do better are the ones who achieve a complete remission with whatever salvage one is doing before transplant. Because if you fail a transplant, the outcomes are really poor. So we have 2 novel agent groups which are approved for relapsed refractory Hodgkin's. One is called brentuximab vedotin, which is a anti-CD30 antibody drug conjugate like Lonca, but it's a different drug. And then we have something called the checkpoint inhibitors, which target the immune checkpoints which are expressed on the Hodgkin cells and the microenvironment. And both these are approved for relapsed refractory Hodgkin's. So we did a study combining both of these drugs, brentuximab and nivolumab, as first salvage, so no chemotherapy. And you can see here a really high overall response rate of almost like 80–90%. And for patients who went to transplant at 3 years, the progression-free survival is 93%, suggesting that about 90% of the patients are cured versus this traditional 50–60% you expect with chemotherapy. So this is now being looked at in the frontline setting, combining these agents with chemotherapy. So there's nivolumab and AVD, or brentuximab and AVD. AVD is a very standard chemotherapy backbone, and this is going on all over the United States. So we really encourage participation in this frontline trial. So in conclusion, there is much better understanding of the biology of lymphomas. There are many advances in lymphoma treatment. There's a pipeline of active agents under investigation. Many novel therapies are approved for the relapsed refractory disease and are now being tested in the frontline setting. The future is promising. So to participate in clinical trials is really critical so that we can make progress in the field. Thank you for your attention.